Last but not the least, pleasure to invite Dr. Liu Hongpang to share with us his insight on IVUS and left main PCI.
Thank you very much. Good morning, everyone. Pleasure to be back in Saigon. Okay, I'm going to talk about IVUS in left main PCI, some tips and tricks. We heard this morning that we have now class 1 recommendation of using imaging to optimize complex lesion PCI, including left main. For left main lesion, we know that angiography can be challenging because of the lesion angulation, eccentricity, the bifurcation, anatomy can be variable, and often even with the best view attempt, we might get overlapping and foreshortening. Imaging, we're able to see from within the lumen and help us from pre-procedure strategize, but also post-procedure optimization, which is particularly important in double stent strategy. So in terms of left main, the tendency for where the plaque can forms related a lot to the endothelial shear stress. You can see in this diagram here, there is low shear stress that is imposed onto the bifurcation, and you see the flow actually causes injury to the local endothelium, and atheroma tends to form opposite the divider or the carina. And from left main anatomy, from an interventional perspective, these are things that we need to know about. Where is the branching point from the mother vessel? Sometimes that's also called the antecarina. The POC, the carina or the divider itself, then the bifurcation angle. If you look at the left one, so this is where we look at the mother vessel and the transition zone on the POC before the two branches. There is the Finet law and the Murray's law that give you some sort of estimation of the relation of the vessel sizes. In terms of the bifurcation angle, the angle that we refer to between the two branches is the angle B. But as we hear earlier, sometimes the angle A, which is from the main branch to the side branch, or even the main branch proximal distal may also be important. And in left main, we know that it can be an osteo lesion per se, or it can be the mid shaft or the bifurcation. And sometimes a combination of all these. And the unique challenge of the bifurcation particularly will pose problem with the side branch compromise, either a plaque shift or carinal shift. And we know some of these actually give us insight. So from imaging perspective, we may actually see some of this information and therefore adjust our strategy. There are predictors for plaque shift and carinal shift. Without saying, of course, if the side branch is small, particularly when the stenosis is significant, the plaque shift and carinal shift are both at risk. Whereas if we have narrow carinal angle or a very short distance between the bifurcation point to the carinal tip, if it's less than 1.7 millimeter, these are all predictor of carinal shift. So the potential mechanism of benefit and how IVUS may improve left main PCI, including this. Before procedure, we can look at the size of the vessel accurately. We can be able to assess the plaque morphology. We can look at how we would use devices to optimize lesion and lumen preparation. And last but not least, that the post-procedure to optimize the result. Tips and tricks. Now, these points here are mainly for the image acquisition. I heard from previous speaker talking about we had to take the image, but also we're going to use the information from the image. We had to act on the image. So that part there will come later. So from the image acquisition perspective, we've got a lot of good technology now, but these are basic. So getting a good guide is important. And of course, always heparinize the patient because there is a risk of thrombosis. Ensuring the IVUS catheter is well prepped and flushed so we don't have bubbles and cause artifact. We should wire all the branches that we're going to treat or protect. It's also good for the landmark as we do a pullback. We should disengage the guide, and then we can see the true osteo as we approach the end of the pullback. Occasionally, we might even put an anchor wire in the aortic cusp to give some stability. And we may need to pre-dilate the vessel. If they're very, very tight sometimes, pushing the catheter down may cause flow obstruction. The patient may become unstable. And it's important to actually do that. And for pullback, I personally like to do a manual pullback before an auto pullback. And manual pullback will give me a point where I can stop and pause to see where is the point of interest, and also give me my idea about the smoothness of the pullback. If the pullback is not smooth, then be very careful about using it for length assessment. And for the left main, we need to do pullback for both the LAD and circumflex, so we can see both the lesion, both the vessel size accurately. We can never peer through the side to look at the other branch. Co-registration in some system have it, but if we don't, the co-registration is up here. So we're going to look at the angio, we're going to look at the IVUS, we're going to learn to look at both. When we look at the angio, we're going to be able to see what the IVUS will look like, and we look at the IVUS, we're going to see what the angio look like. So that's something we all need to learn to train. Okay, so pre-treatment, basic, establish the lesion length, define the landing, and this is where we look at what's normal to normal by angiography, and we cross-check that with the IVUS grayscale and see, okay, if my angio reference is here to here, whether the IVUS matches. If there is a plaque which is more than 50%, then we have to consider whether we need to cover that. Plaque morphology, very important, particularly when we talk about calcium, we talk about very fibrotic plaque, because the lesion preparation can be more challenging. And of course, vessel sizing. And we're going to talk a bit more about that. So we look at sizing. We need to look at whether we are sizing by the lumen, where we look at the axial diameters. We need to look at the minimum and the maximum axis, because they can often be eccentric. And we heard from previous talk the importance of assessing the area. And the other sizing is, of course, looking at the EEM. And this, again, we have to look at the axial diameters and again look at the area. The landing edge are important, particularly, when we look at the plaque, remnant plaque burden that might be cut by a stent edge. IVUS is not just for pre and post. And this is something that I encourage people to read about. IVUS can also be useful intra-procedure. So this is a real-time IVUS guiding, particularly for osteostenting, which can be for osteo left main as well as osteo RCA, but also an osteo side branch of the left main, like say the osteo LAD. And this is something which is published earlier this month. I have the reference there. It's published from the New Zealand colleague, Sarah Fairley, and it's very, very elegantly done, and I would really encourage people to go through this. Basically, we have two wires. One wire for the IVUS and the other wire for the procedure to the target lesion. And this is to place the stent accurately at the osteo, either the osteo or the aortoosteo or the side branch osteo. So like in this case, you can see if you have a bifurcation like a 0-1-1 or 0-1-0, there's a potential to use this technique. So otherwise, post-procedure, we had to look at whether we have covered the lesion and also cover it well. So we may look at undersize or oversizing, where you have a mist or a dissection, opposition or well-opposed stent or malapposition. And then, of course, the stent expansion, which we're going to focus a little bit more here. And we heard from previous speaker about this. We had to look at the reference, the stent area, as well as where is under expansion. Now, particularly in the left main, there are certain things that we need to look out for. So for osteo lesion, we sometimes have a geographic miss. We might have excessive stent protrusion. We may have remnant disease or even unintentional stent deformity, where the collision of the guide crushed the stent edge. Left main bifurcation per se, we might have, as we heard, carinal shift, a plaque shift, and of course, even malapposition proximal to the left main, when the stent sizes are very, very discrepant between the proximal and the distal segment. So here's an example where you have a proximal stent which is hanging, and this is where you have to take note, and the IVUS will be able to see it. This is something important pre-procedure to take note the sizes, because we need to know the size of the stent that we're going to use and ensure the stent that we use is able to expand adequately. So each stent usually will have the information about the maximum stent expansion, which we need to read. And it's usually not on the chart, but on the box, and I give you additional, I say maximum stent internal diameter that we need to look out for. And we heard about this, the importance of optimizing the size. And we heard that there are criteria that over time has evolved. The earlier one from Kang, we'll talk about the 5, 6, 7, 8. Then we have the Excel registry that talk about a little bit larger, 6, 7 to 10. And of course, we heard now the latest from Kim that we need to aim higher. And I put a clock there to keep it easy to remember. So you look at the clock there, 6 to 7 for the left circ, 8 to 9 for the LAD, and 10 or 11 more for the left main. But it's not just the absolute size. We also think about if you are small vessels, a small caliber vessel, we can't aim everything according to absolute. We had to look at each segment. So here, we look at the right side, there's a magic number there has been quoted like 90% and 40%. Now, what does that mean? This is relating to how we measure stent expansion. So measure expansion, we look at the mean stent area, divide by the vessel area at that particular site. So this is one way. Then there are others. Last but not least there is to look at the stent expansion of the stent adjacent to the segment that it refers to, so the proximal end and the distal end. Then there are papers that look at this. For instance, this is where we look at when we have size of stents of less than 4.5 for small vessel or larger vessel or more than 7.6 or anything in between. It is very important to achieve that ratio of the MSA to the reference vessel of at least 38.9%, 40%. So that's where the magic number comes from, the 40%. So you can see that difference is so much more important when we deal with small vessels. Yeah, that we can have a TLR rate, which is actually, or stent thrombosis rate, which can be doubled if we do not have that optimized. So that's where the magic number came from, down there, the right corner. Okay, so this is from the Fujimura paper. Then, of course, we also know if we can get it larger, we get it larger. So it's not just about, hey, stop at 10 o'clock, stop at 10 and 12. If the vessel is large, sometimes it can be even more than 15, it can be going more than that. So here's a paper, again, which shows that we can expand the stent well, we can reduce the risk. So if you have, for instance, you hear a smiley there, a left main, an MSA of more than 13, okay, you have a 5-year near zero, a left main stem TLR rate. If we don't, then of course, the risk is still there. So good that we individualize it. So just a few cases, I've got 30 seconds. Here's a 62-year-old with a left main and an LAD disease. You can see here the bifurcation. The LAD osteo also has an aneurysm. So in this case, we do an IVUS, and here I declare my conflict of interest because I came here under the sponsorship of NIPRO. So there's an IVUS, which is showing the Makoto, which shows the grayscale as well as the lipid pullback. At the top there, you can see the LCBI, which is a high lipid score, very high lipid, high vulnerable plaque. So in this case, of course, we can see there is a lipid and it obscures the vessel sizing, but otherwise, after we do a lot of lesion preparation, we are able to use a combination strategy of stenting the left main, DCB, the big LAD, and we got a reasonable result. Okay, so this is based on IVUS sizing. I'd like to go back 2 slides here. Oh, sorry. If I can go back, I know time is up. I know 10 minutes is going to cut the slides, right? Okay. I just like to show you. See this here? Where the line is cutting, that's the angio and grayscale IVUS-based decision of what is okay for landing. But when we look at the lipid there, we're cutting at the lipid. So this is where there's additional value to tell us maybe we should not land the stent where that lipid is. We should try to cover that lipid. Okay? So there's some of this technology which we need to evaluate. I'll show another case now. Earlier on today, we heard about a patient who had 2 stent Q-lot and came back with ISR. And I want to show something similar. 72-year-old, hypertension, diabetes, came back with a recurrent angina. He had DK crush stent in April 2024. Okay, it was a beautiful result. I was guided as well. Look at all the stent area. Pretty good, pretty optimal. Unfortunately, the patient came back with this. So he has restenosis, bifurcation. So what do we do? So again, very important. IVUS, not just looking at the lumen, but look at the mechanism of the restenosis. So in this case, they are both mechanical as well as biological. So we need to correct both. I won't read the details here, but basically we know there is undersize, underexpansion, as well as some neoarthrosclerosis. So there was a LAD, the IVUS run, and this is the circumflex. So I'm going to move very fast. The lesion was prepared initially with 2.5 to get a bit of space. Then we use a scoring balloon. And because it's IVUS guided, we're very confident with the sizing. The circ is larger than the LAD in this case, so we use a 3.5 scoring because there was a little bit of calcium, so we don't want to be oversized. Then followed by a 4. And then we do the LAD likewise. And this is after the lesion preparation. We even kissed it to restore the geometry of the stent and pot it as well. And this is just ballooning preparation. And we take note when we do this, the patient do have hypotension. So not very stable. So what do we do after this? More stents? So quick hands up. Who would say put more layers to stents? Hands up. Who would say put DCB? Oh, a few. Okay. And who would say a combination of both? Okay, so this is how I just show. So earlier I was very interested to hear Dr. Chow, who presented from Vietnam, how he did it. 1 minute. And I always say, wow, will the patient tolerate such a long inflation time? Good thing is when we prepare these patients, we precondition them. So pre-scheme conditioning is very important. But this patient, even though we tried, the patient was not able to tolerate 1 minute. So what we do here is we park a microcatheter in the vessel before we deploy the DCB. So in this case, you can see here, we put the microcatheter and we deploy the DCB. And you can see how, as we deploy, we can still inject blood. So I'm just demonstrating here injecting contrast. But what we do is harvest 10 mL of blood, and we inflate the DCB when we inject blood. So that will prolong the ischemic tolerance time. Okay? So this is what we do. Sequentially, we do for the LAD, then the circumflex, then the left main. Okay? So I foresee this is going to come back more because we have done so many DK crushes, so many two stents. We're going to come back. These people, they live long enough. We're going to see a lot of these patients coming back. Okay, we need to really learn this. So this is a post-PCI, the IVUS. Hopefully this time it will be more durable. This is Malaysian data, left main, and the bifurcation. And so far, we still use a stent in 80% of our cases for left main, but we do have about 18% of cases that we use a combination of DCB. So thank you very much. Final slide. So the guide tells us we need to use IVUS. It's evidence-based. It's class 1A. It's useful for pre, useful for post, particularly with two stents. And for future, I believe, DCB strategy, we need to assess whether we could accept a dissection, whether there's such a DCB optimization criteria. We need to do more research. Thank you very much.
Thank you very much, Dr. Liu. I think we are left with no doubt that intravascular imaging is mandatory in the left main PCI. And so because of time constraint, so I'm going to call the end for this particular sessions. Thank you very much and enjoy the rest of the meeting.